Hello and welcome to Combat COVID-19 Community Support. We're so glad that you've joined us today for a really hot topic and an amazing guest speaker. Dr. Laura Pennavaria will be talking about immunity testing and COVID-19. That really quick, but we do have a couple things to go over. First of all, who we are. We are an informal coalition of healthcare providers and other community leaders in Central Oregon, and we're working together to bring you this series of live events focused on how you can care for yourself and your family during the pandemic. We do have to follow really quickly this disclaimer and let you know that this event is provided for informational and educational purposes only. It is not medical advice or medical opinions. If you do require assistance with any mental health or medical issue, please contact your healthcare provider. And with that, I am super proud to introduce Dr. Laura Pennavaria. She's going to speak for a little bit, and she's agreed also to answer your questions today. So please feel free, if you're joining us on Facebook or YouTube, type in your questions, and Dr. Pennavaria will answer those at the end today. And with that, I'll hand it over to Dr. Pennavaria.
Great. Thank you very much. Hello, everybody, and thank you, Dawn, for that nice introduction. So I'm just going to start by going over a little bit of what are antibodies and antigens. So an antibody is a protein that's produced by your body in specialized blood cells in response to a specific antigen. And an antigen is a protein, usually a foreign protein, that induces the blood cells to make antibodies. And so antigens can either be naturally occurring, like a protein introduced by a virus like COVID, or they can be purposefully given in the form of a vaccine in order to induce antibody production in the host or in the person. So what antibodies do is that they combine chemically with antigens, such as bacteria or viruses, which the body recognizes as alien. This chemical binding targets the antigen for destruction, and that destruction can happen by a variety of pathways. But the first step in your body ridding you of this foreign substance is that antibody and antigen combination. It's the first step in your body's fight against the pathogen. And different antibodies work, as I said, there are different pathways. The best antibody response you get is what's called a neutralizing antibody, which is as soon as it binds, it neutralizes that antigen and that antigen can no longer work or hurt you. Other antibodies, they might combine and maybe slow it down, don't really neutralize it right away. So there's a little bit of a variety there and things that can happen with antibodies. So the different types of antibodies, you might have heard of IgM, IgG. There are also IgD, IgA, IgE. We're not going to discuss those today, but IgM is a mucosal antibody. It shows up early in an infection, and it's transient. So when we see IgM, usually that signals to the doctor that's looking at it that the infection was fairly recent. IgG shows up when IgM's still there, but then that's the enduring antibody that's there that is long lasting and that you'll see later in life. And that's the one that stays and can be reproduced if the infection is reintroduced. So at what point in the COVID illness can antibodies be detected on average? What we've seen in the literature is that at 11 days, at day 11 of illness, you can start seeing antibodies. IgM usually shows up at around 12 days, and IgG shows up around 15 days. And what we've also seen from a clinical standpoint is that the illness really starts to take a turn for the worse in most people when they are having a very severe case at around day 8. So we're not even seeing antibody when the illness is at its peak. So how reliable are these antibody tests? And that's the big question. Every test, no matter what it's testing for, has a sensitivity and a specificity. Sensitivity is what that means is that when people actually have the disease or they're actually immune, how often are we actually picking it up? So in 100 people, if 100 people have the disease, this test will pick it up in 95 of those 100. That means that its sensitivity is 95%. Specificity is when people don't have the disease, how often is the test negative? That's a very important one for COVID testing because there's so many different coronaviruses. And so what we really need is for this COVID antibody test to be specific to COVID antibodies, and not because you likely have antibodies in your body against a variety of coronaviruses. And so we don't want to just pick those up and think you're immune to COVID, right? So that's the big task of these companies that are making these tests right now. They're really trying to make sure that they're specific. And so both of those numbers, we really need those numbers to be high. And they're also affected by a lot of different variables. They're affected by how prevalent the disease is and whatnot. This is just kind of a little graphic so that I could show you kind of how that looks, what sensitivity and specificity is. So when you're testing for the virus, you're getting that nasal swab. That's so much fun. The positive, if you have a positive test, if it's a true positive, you're looking at the sensitivity. If it's a false positive, that's the person now doesn't think they have COVID, but they actually do. And then the specificity, as I said, was the true negative. Same goes for antibody testing. I'm not going to spend a whole lot of time on this slide. So how reliable are the antibody tests? And that's what I was just kind of been talking about. But there are several manufacturers, and they're all going to have their own numbers for specificity and sensitivity because each test has its own specificity and sensitivity. And that's what the FDA is looking for before releasing these tests for general use. So as I said, each manufacturer has it a little bit different. But for the IgM, the numbers I'm seeing have been in the range of 85% sensitivity and 96% specificity. But for IgG, it's been looking better, 99% sensitivity and 98% specificity in the tests that I've seen. So those numbers are still under development because the test makers are having to test them on a sufficient enough sample for the FDA to say, yes, those are reliable numbers, and we're going to let you use that test. So I just want to point out that any test that you as a consumer are able to purchase right now over the internet that's an antibody test for COVID is garbage. Please don't rely on that test. Okay, so you really are going to want to wait for these tests to be released by the FDA for physician use. And the way that we use them is that we consider what the risk factors are for these folks before we test people. So what are the implications of antibody testing? So once there's a certain level of immunity reached in any given geographic area, that area is considered to have herd immunity against the disease. And that percentage is not the same for every disease. For example, with pertussis, you have to have about like 92 to 94% immunity in order to have herd immunity. And mumps is even lower. It's probably around 80%. But, measles is high, 95%. And what happens with the ones that I just mentioned is that immunity kind of wanes over time, goes down. And so people need boosters of their vaccines for those disorders. And so and people aren't usually very precise at getting their boosters right on time. So with pertussis and mumps in particular, we see kind of this like undulating pattern of like minor outbreaks in any given community for those reasons. And so herd immunity, we've heard a lot said about herd immunity, but we don't even know what percentage that we're going to need to get to have herd immunity in this case. And also much has been made of these tests being the key to opening the country back up. And that would be fantastic if we could just have a test and it could say, yeah, you can go back to work. that'd be fantastic. I'd love that. But there's kind of more to the story there. So we need to find out, can someone be immune and still shed the virus? We actually don't know that yet. And if we check for antibodies soon after the illness, that may not be enough to release someone back to work. And then, as I mentioned, how enduring is the immunity? And that depends on virus factors and host factors as well. Also, how effective are the antibodies? As I mentioned, some antibodies are neutralizing antibodies. Is that what we're seeing here? What percentage of immunity? As I mentioned, we don't know to get to herd immunity right now. And then how quickly is this virus mutating? Some viruses mutate very quickly to avoid our immune defenses, like colds. Other coronaviruses mutate very quickly, and other viruses are unable to overcome our immune system. So we don't know where this virus will land. There's another SARS virus that causes SARS, and there's the virus that causes MERS. Those are both also coronaviruses. And what we've seen is that they're not mutating very quickly. The immunity is lasting a couple of years there. So I don't know if it's going to be similar to that, or it's just not known yet. Oh, sorry, this is just a shameless plug for my practice. So that's about what I had, and I'm open for any questions.
Thanks, Dr. Pennavaria. That was really great information. I was actually wondering if you could go back to the slide you just had up there, because I know some of the terms that you used on there, I actually wasn't sure what that meant. So, for example, like how effective are the antibodies when you talked about them being neutralizing? Could you explain a little bit more about what that means?
Yeah. So antibodies, what they do their work. They help the body do its work via different pathways. And some antibodies are neutralizing antibodies, meaning that as soon as they bind to the whatever part of the virus that they're binding to, it's usually like a surface protein or a glycoprotein or something. As soon as they bind, that and that virus is no longer able to enter the host cell and can't do anything except for die. And so those are like the antibodies you really want to have, but it's not up to you what kind of antibodies you get. It's whatever your body produces, and that's whatever is produced against this disease. And so it would be great, and there are a lot of different organizations working on a vaccine right now for this, and they are working on trying to make the vaccine induce your body to produce neutralizing antibodies, which would be fantastic. So did that clear it up?
Yeah, thanks. I thought that was helpful. So okay. I'm also trying to get an idea in my mind of like kind of the timeline and some of the implications, right? So we have the vaccine that seems to be a ways out, right?
Yeah, probably 18 months, 12 to 18 months.
12 to 18 months, yeah, seems to be what we consistently hear.
Yeah.
But like the immunity tests that are going to be coming out, what are some of the more immediate, like how do you see that playing out? Like, is it something where people can go to their healthcare provider, they can find out if they're immune, and then like, could we on me based on that? Like, and I realize some of this might be a little bit of speculation, but like, how do you see this potentially playing out?
So Dawn, you cut out just a little bit. Could we do what based on that? What was your question?
Well, like if we know that people are immune from these tests, could they potentially go back to work, or they could be ones like opening the schools and being be teachers? What are the implications for society as these immunity tests start rolling out?
Yeah, and that's the $1 million question, because ultimately, I think it will be really good for us to know how much of our country has been exposed to COVID, and long-term antibody testing could give us some information, some answers about that. If we know that, if we could do imagine we could do widespread antibody testing of the entire population. That would give us a much better idea of what the denominator is, how many people actually got COVID. And that will tell us more about how deadly COVID really is. So that's one important piece of information, but kind of more immediate. People are wanting to kind of use it to go back to work. And you know, perhaps using an antibody test combined with another nasopharyngeal swab to make sure that you're not still shedding virus, that might be safer to say someone can go back to work, but also depends on what they do, right? For work. And then also, I think that one thought I had was that it could be useful in the more near term to for households to kind of understand family quarantine a little bit better. So if one person in a household is diagnosed with COVID, what's the status of everyone else? You know, and how do we isolate within this family, right? So how do we isolate the folks, or do we have to isolate the folks within a household? So.
Okay, great. Well, we do have a question from one of our viewers, and I'll just read it directly. It says, I saw recent data published by Harvard researchers saying that we may have to keep social distancing measures until 2022. Even if we have a vaccine in 12 to 18 months, will this still be the case? What are your thoughts on that?
Well, you know, I think that we're entering a new time, a new normal. I think that we are going to be dealing with some social distancing for quite a long time, several years, I would say. That doesn't mean it's going to look like it does today, where everybody's working from home and you know, going to the market once a week with full gear, you know. But I think that we will be dealing with some changes. You know, this has really brought a lot of things to light. For example, it's kind of amazing that we've had to really teach people to wash their hands frequently, and you know, but people are starting to do that, and that's going to help. A lot of people have started working from home, and I think that we've discovered as a society that a lot of jobs can be done from home. And so there may be more remote work, and that's just going to kind of naturally lend itself to some social distancing to have. So I think that we're going to see some policies develop either in the government or in a community or with employers where these policies that go into place kind of naturally promote social distancing. So I think that it's going to stay around, but it's not everything. And it's not going to be like it is now forever.
So I'm going to interject.
Got it. Thank you. That makes me feel a little less depressed. But on that note, we do have a live session tonight on dealing with depression during COVID. So please join us at 6:00 for that. I'll just plug that really quickly. So right now I'm not seeing any other questions from audience members. But also we have Matt from Hand in Hand Productions. Matt, did you have any questions for Dr. Pennavaria today?
I did. Hello. Hi. You mentioned shedding of the virus. Do we know?
Matt, I think you're on mute.
Hold on. Oh, you guys have me muted coming back to you.
Oh, there we go.
There we go. I was not muted in the stream. However, you guys couldn't hear me. Yeah. So you mentioned something about shedding of the virus. Do we know what does this virus look like? And can you explain what shedding is, I guess?
Sure. Yeah. So the virus it really is just an RNA plasmid, you know, with a little envelope around it. And it's not even a living thing, to be quite honest. But it replicates. What a virus does is it enters through the nose and replicates in the nasopharynx, in the nose and the back of the throat, by entering host cells and kind of taking over their protein making mechanisms in order to just duplicate itself and make millions of copies of itself, and then it bursts the host cell, releasing all of these copies of the virus into your system. And that's called viral replication. And so that happens kind of in the nose. And that's why we swab in there to see if there's still virus in there, because if you have virus in your nasopharynx, you are shedding it every time you sneeze, breathe, talk, sing, cough, laugh, so you're shedding virus if it's there. So when we test you, there are false negatives, of course. That's another thing about the COVID testing, but you need to get a decent sample. I think a lot of the issues with false negatives have been sampling error, because I don't know if you've ever had a nasopharyngeal swab, but it feels rather like a brain biopsy, and it can be unpleasant. And patients often, like it when you're going to do it, they kind of put their heads way back. Mm-hmm. And so, it's not, you have to get a good sample, and some places are having people self-sample. And I'm going to say, a lot of people may not be quite getting the sample that they need to get.
I think the piece of anybody I think they're testing for flu now differently, but the old flu tests were one of those, like, you're like, oh my God.
Yeah, for sure.
So the question is so when you do the swab, then it's in your, it's there, but mm-hmm. you can have those antibodies present in your bloodstream without them being also in your nasal cavity. Is that what I understand?
So the antibodies are not in your nasal cavity. The virus is there.
Okay.
The antibodies are in your bloodstream. So it's two different tests. We're testing your blood to see if you're immune or you have some antibody. And then we're testing in your nose to see if you have virus. So as I mentioned, the antibody is showing up, IgM around day 12, people are still sick. So they're starting to see that they have antibody, but even, we've seen that there's a lot of asymptomatic shedding, which means that there are a lot of people walking around with COVID in their nose that, don't know it and are potentially infecting others. And that was the reason for the suggestion to wear a mask mm-hmm. in public. In case you are shedding virus, you're going to be protecting the people around you.
Right. Yeah. Dawn, did you have any questions from the chat room? I'm not monitoring that, so.
I'm not seeing any other questions, either on Facebook or YouTube, but I'm actually really enjoying this time to get all my questions answered for Dr. Pennavaria. So if she's willing to hang out for a couple more minutes.
Oh, sure.
I'm looking at, that last slide around the unanswered questions, and also still in my head trying to make sense and think about it in terms of other viruses, right? Like you mentioned chickenpox and things like that. Mm-hmm. So, because some viruses essentially have them forever. They're just kind of dormant in your body, right? Mm-hmm. But other
the virus or the antibody? Yeah, chickenpox is a little different. I mean, there are some let me give you the example of tetanus, for example. So tetanus toxoid is everywhere. It's everywhere. And if you actually contract tetanus, you don't produce, your body will not produce antibodies against that. We have to give you a vaccine to have your body produce antibodies. So it's the whole science of antibody immunity and antibody production and all that. It's just fascinating. But yeah, some viruses or some viruses we're no longer susceptible to after we've had it once. Varicella in particular, it's not when we see that resurgence, which is not, it doesn't show back up as chickenpox. When you've had chickenpox, it shows back up later in life as, I'm trying to think of the lay name for it now. It's called zoster. Shingles. Sorry,
yeah,
shingles. Yeah. So it shows up as shingles, and that's because what the virus does is a very strange virus, and it goes in and it joins a certain level of your spinal cord, and it lives in this little thing called the dorsal root ganglion at one level on one side of your body. And that's why when you get shingles, it's always like around one side. or that kind of thing. So it's just because it just reactivates right there. But your body has antibodies and it eventually fights it and puts it back in its place. So
I had a question and it just escaped me. This is sort of a random question, but how did you get into this field of study? I guess I'm curious more to know what drove you to where you're at today.
Well, are you talking about just immunity and stuff?
Yeah,
because
exactly.
This is just, well, I don't know. Sometimes I say jokingly, I've been to doctor school. We learn all of this in medical school and more, way more. So, I really, this is so fascinating to me. I could talk about it all day long. It's just when I learned in school and have continued to study during my career and read. Physicians just are lifelong learners, and just reading constantly. Mm-hmm. I wanted to mention one more thing about the coronavirus and about COVID, and that's that so far we have not seen confirmed reinfection, and that's an important thing for immunity, because when I was talking about like how long lasting is the immunity, how effective and how long lasting, those are the two big questions. And so there was one Chinese study that kind of showed there was someone that was reinfected, but then they kind of walked that back a little bit and said, I think what happened there was that he had a positive test, a negative test, and then a positive test, and it was a false negative. That's where they're kind of saying that it's a false negative in between the two tests, the two positive tests. So that's kind of where what they're seeing now. But the virus has been around long enough now for us to maybe have seen some reinfection, but that's still something, it's another thing that we don't know about COVID yet. And that's the reason that we really can't say, oh, you've got antibodies, just go back to work.
Right. And when you talk about reinfection, that meaning that you've had it, you've gotten through it basically, and you won't have those symptoms again. Is that what I'm hearing you say?
Right. If you don't have reinfection. But if you have had COVID, like you get multiple colds in a year, right?
Yeah.
The reason for that is that there are different families of viruses that cause the common cold. There are coronaviruses, adenoviruses, parainfluenza viruses and whatnot. And there's a whole bunch of different ones. And so you can get a cold and then you get another one. You don't usually get the same cold twice in a year. But you might get that same cold the following year, or, because the virus also itself mutates and overcomes our host defenses. And if this virus, if our host defenses target a specific protein and the virus mutates that, we have to start from the beginning again. So.
Right. Okay. That makes sense. I was just curious on that. I appreciate that, because I think that's probably a concern that people are thinking about. Well, I've gotten a cold. Why can't I just get it again? So I appreciate that clarification. Yeah.
Yeah.
Yeah. And so I just want to, off the top of my head, go over a few, I think, key points that you said today, Dr. Pennavaria. Mm-hmm. Number one, that if we're seeing any kind of advertisements online to purchase COVID immunity tests right now, those are scams.
Yeah, absolutely.
And we should not trust those.
That's correct.
We should wait until our healthcare provider actually has the tests in hand and get them from a healthcare provider.
Yes.
Okay. Yeah. And the timing for when those immunity tests are.
I heard from, so the supplier that I am buying mine from, I talked to them yesterday, and they said they was looking like 2 to 3 weeks. What's happening right now is that the FDA gave one company, a company called Celex, an EUA, a letter that said you can go ahead and use your test. That test in particular is not like a point of care test where you prick the finger and put a little drop of blood on the test strip. It's it requires a venipuncture. So while it's point of care, it's not a peripheral. And so doctors with a CLIA waiver can't use that test unless they have a specific kind of a CLIA certificate. And so most doctor's offices are not going to be able to use that test. It's going to be useful for health departments, I think, and but the remainder of the manufacturers are really trying to get this point of care test to the market for CLIA waived physicians and organizations. And so it's going to, each one of them, as I mentioned earlier, is having to do their own studies on sensitivity and specificity. And when they get to a level that's acceptable to the FDA, they'll be given permission to distribute their tests. I also, sorry.
Go ahead. Yeah.
That's okay. I also would recommend and really encourage you to do any kind of testing in conjunction with your physician, because you're not going to be able to interpret that test. I mean, you'll be able to see if it's positive or negative, but what are the implications of that for you in particular? And that's what your physician can help you sort out.
So that actually leads me to an interesting question, which somebody threw this in my comments from a watch party I started on Facebook. The drive-by testing or some of these other things that we're talking about doing, do you think that in order to get your results, they're going to have to go to your physician? I mean, what's going to be that best strategy in your opinion, I guess?
Well, I don't know. In terms of the drive-by testing, I'll tell you that who's responsible for a test is whoever ordered it. And so I understand St. Charles is opening up some drive-through testing.
Yeah, drive-through would be better than drive-by. Yeah,
they're doing it too. Yeah, right? I'm gonna drive-by test you. No, so I think they're doing it, but they're requiring a doctor's order, which is good, because that means that the result goes back to your doctor, and your doctor can help you interpret it. So it's not just anybody that shows up can get the test, which is perfect. That's as it should be. And so, but if people are somehow getting tested either for antibodies or for COVID outside of the context of a physician-patient relationship, they're going to be not know what to do with the results very well, is what I'm saying. So,
okay, no,
allow us to help you interpret that, and what that means for your health.
Yeah, absolutely. No, it makes total sense.
It does. And we do have another question from a viewer, which is, when things start to open back up, what kind of businesses do you think will open first? And then the sub question, sports and other entertainment-based activities will be the last to open.
Do I think that? Okay. What I think will open first is probably schools. And the reason I say that is that children are at much less risk. And in order to have a kind of meaningful reopening of society, people need to not have to homeschool their children. I don't know how else to put that, but people are really struggling with that. And but I do think it makes sense to open schools up first. I think we're going to see some businesses that are just not going to be around anymore. I think there are some individual businesses that are probably not going to survive this, but entire industries might go away. I mean, I don't know. It's impossible for me to predict, but I mean, movie theater, that's probably a low priority to reopen. And sports and entertainment. Well, I think, you can't prioritize sports and entertainment over health and life. But during this pandemic and the social isolation that it's led to, people have really seen the importance of sports and entertainment and how much those things are meaningful to us. And so, I mean, I have to say, I applaud in particular the NBA for shutting down very early. They were the first. And, all of those folks, that's their livelihood, of course. But we're going to have to kind of think about, how do we reopen and how do we reapproach some of these things that we've traditionally done in maybe a different manner? Like, are we going to need to have social distancing at schools, at sporting events, supermarkets? Are we going to sit in a different way, not as crowded. Wouldn't it be great if like airplane seats were bigger? Right, for example. But I mean, I think there are a lot of things that we're just as a society going to have to start rethinking. What is safe? What's not safe?
That's actually interesting, because that is an interesting thought, because we have been conditioned to sort of everything's fine, we're safe just the way we are, but now the reality is that it is different.
We may not be.
Mm-hmm. Yeah.
For the long haul.
Yeah, and what I think I hear you saying too, that feels a little bit overwhelming, but I have to admit that I kind of had that in the back of my head, is that this will fundamentally aspects of our world kind of going forward. Agreed. Even after we start to come out of this, we may see long-term changes in how, and maybe this has all kind of laid bare how unprepared we were as a world and for all of this. So some of these might be good changes. Absolutely. Right?
Agreed. Yes.
Yeah. So, okay. So we've got, key points. If you're seeing immunity testing out there for sale right now, do not buy those.
Right.
Wait for your healthcare provider, your physician, to have those tests. Secondly, there's still a lot of unanswered questions that we don't know. But it does seem like there's a little bit of hope because we haven't seen people who get the virus and recover from the virus get it again. We haven't seen that. Doesn't mean it won't happen, but at least right now we haven't seen it. So that provides a little bit, I think, of hope, right?
Yes.
Good. Thank you for saying that. Yes. And that, I think the third key thing that we've discussed today is really how things are going to change moving forward. And we're not going to be in this total lockdown, forever. Things will start changing, but at least it sounds like for a couple of years, we're going to see changes that we're going to have to make based on this. Some form of social distancing is going to have to be kept in place, maybe intermittent or not as extreme as now, but still going forward, we might have that. So is that an accurate summary kind of everything we talked about today? Did I miss anything?
Yeah, well, I think that gets most of it.
All right. Excellent. Well, I'm not seeing any other questions from audience members. So with that, I do want to say thank you, Dr. Pennavaria, so much for joining us today. Absolutely. And Dr. Pennavaria's practice is Homestead Family Medicine. She's a family physician who admitted today that she's a little bit of a geek when it comes to stuff that she finds super interesting and loves to read about. So she was the perfect guest for us to have today. I do want to invite you all to join us again at 6:00 tonight. We have another live event with two amazing behavioral health clinicians from Summit Medical Group here in Oregon. They're going to be talking about, are you feeling depressed during COVID? How to deal with that. And so please join us at 6:00. And then we're going to finish out our week of programming tomorrow with Dr. John Peoples. He's a wonderful pediatrician in our community. He's going to be talking about everything you need to know about kids and COVID. And he's would love to answer your questions as well. So join us tomorrow. And then please go to our Facebook page to see our live event schedule for next. Continuing to add new events all the time. And thank you so much for joining us. You can view them also recorded on Facebook and YouTube. And we did get a comment from one of our viewers just to sign us off that says, good public health background too, from Dr. Maria. So I didn't mean to neglect that. You're absolutely right, Karen.
Forgot about that, yeah.
A comment on that. So, and thanks to our production partner, Matt at Hand in Hand Productions. And we'll see you at 6:00.
Bye, thank you.